safety profile is also good. And when it was given as a primary dose, after initial dose of hepatitis B and OPV, the incidence of injection, there are adverse event also recorded where injection-related pain, swelling, some erythema was seen, and associate and systemic reaction such as some irritability, incessant crying, and pyrexia was also noticed. But the incidence of these side effects were significantly lower as compared to wholesale. Although we have around 30% children having pain associated crying, associating irritability, 24% had swelling, 24% have some fever, but still, as compared to wholesale, this quality of life of a young 6 week is better with acellular, and it helps in mitigating vaccine hesitancy as well. Next slide, please. The review and research done in CMC also showcased that it has induced a very good immune response against hepatitis B. And without hepatitis B at birth, in group 1 and group 2, we see that titers were low, but in group 3, group where the hepatitis B at birth was given, the titer were good enough to have a good long lasting protection. Seroprotection rate in group 3 was the maximum as compared to other two groups. And this reinforces that relevant hepatitis B in first as a booster is very relevant for improving titers in child. Next slide, please. One important aspect which we should not forget that there are very minimal evidence available when we do co-administration of wholesale vaccine with Prevnar 10 or Prevnar 13 and Rotatec as well. Next slide, please. In this slide, we see that ready-to-use hexavalent vaccine as compared to there is inconsistent as compared to for vaccine which need reconstitution, there has been increased reporting rate of convulsion when reconstituted vaccines are utilized with pneumococcal, both in clinical studies and in post marketing. There is no co-administration data available for wholesale pertussis hexavalent vaccine along with co-administration of other vaccine, and ready to use hexavalent vaccine have showcased that they are safe enough to be used alongside with other vaccines if given at various stages in age of child. Next slide, please. So, does like I've mentioned, does it really help healthcare practitioners? Next slide, please. So, studies have shown that they have lesser, like 5 times lesser errors, quicker to reconstitute, 50% reduction in prep time, safer, easier to handle, precise and accurate dosing, reduced spillage, reduced wastage, reduced litigation, reduced parental discomfort, reduced loss of money. I had a personal experience of one of the doctor telling about hit of 4,000 some change because they have ultimately has to redo the vaccination on the expense. And when we engage our our support staff to prepare vaccines, it is inviting more trouble. And there are incidents in every clinic where there is spillage, poor constitution, some medicine left, or some left the or some medicine not prepared well, the clumps are there. So this all can easily be managed by ready to use vaccination formulation. Next slide, please. Next slide, please. So combination vaccine in fully liquid formulation are safer. They promote confidence within general population and healthcare practitioners. And even study in Korea revealed that more than 90% healthcare practitioners prefer ready-to-use formulation over reconstitution, as their success rate and comfort for the parent and patient are more. Next slide, please. Are they safe for preterm babies? Let's see. Next slide. When we compare preterm with term baby, we see that 1 month post primary series and post booster immune response in preterm and term baby vaccinated with hexaxim at second, third, fourth, and 13, 15 month with no hepatitis B at birth and co-administration of PCV 10 and rotaviral 1 and or rotaviral 5 was taken, then the titers are comparable. Seroprotection is comparable. And next slide, please. Product insert also mentions that the side effect at the injection site in preterm are more as compared to term, where pain, induration, to some extent nodule, which is bare minimum in term baby. In preterm, there is these chances are more, and overall the reaction or adverse reaction following first dose of hexaxim as compared to term baby are more in preterm. So we need to be aware of this fact. Still, in comparison to wholesale, it is way lesser. And next slide, yes. So the journey of Hexaxim from 1982 with registration of IPV standalone to 2012-13, where registration of hexavalent vaccine with combination of hepatitis B antigen has happened. This clinical journey take lot of research, lot of work from learned scientists, with lot of efforts from healthcare practitioners uh, comes into action, and this journey need not to stop. We have to keep on going ahead. The virtue of ready-to-use acellular pertussis hexavalent vaccine is to induce immune response in multiple schedule. The median and says the statistic analysis showcase that strength of antibodies are there. Real world experience and acceptability by healthcare practitioners are studied. They are safer and well tolerated, and co-administration or with other vaccine routinely utilized is safer with ready to use hexavalent acellular vaccines. Next slide, please. At toddler level, we choose Pentaxim. Toddler booster, we see that even ACVIP recommend DPT, HIB, and IPV to be used as first booster in toddler age group. Hepatitis B vaccines are not needed in healthy children, and pentavalent vaccine containing DPT, HIB, and IPV are a good choice for routine booster for toddler age group. Next slide, please. Next slide, please. The pre-booster and post-booster levels also showcase that immunistic response is better. Indian registration study revealed that after having 207 healthy children participation, the booster Pentaxim at 18 to 19 months of age with priming, which has been done with Pentaxim at 6, 10, 14 with hepatitis B vaccine in year 2012. At that time, the relevant post booster seroconversion and seroprotection was immense. And this good levels are very helpful in preventing and mitigating risk of further problems. Next slide, please. This slide also showcased that immunostic response with the median control levels after booster dose are consistent with the long-term protection against with exact. Next slide, please. At a school entry level, if next slide, please. If the boosters are not given, the sudden dip in the concentration of protective titers has been seen. Thus, it is mandatory for doctor to reinforce usage of boosters. Antibody level in circulation technically wanes off after primary vaccination, and the level is below the level of protection. This is dependent on age of the vaccine recipient. We are talking about less than 2 years for all, and then the nature of antigen, then nature of immune status of the child, number of booster dose administered helps in maintaining the antibody level, which has a protective threshold, and very high rate of vaccination, that is absence of pathogen transmission, may also prevent natural boosting of vaccinated individual, and that can also lead to waning immunity. So that in combination of associated immune status of the child, everything, every aspect will work for improving and generating a robust and protective immune response. Next slide, please. The This slide showcased the duration of persistence of antibodies against diphtheria and tetanus toxoid. Usually, the decline has been seen around 4 years of age, and if the boosters are not given, the further decline will be jeopardizing the protective effect. So, giving booster is mandatory, and it helps in maintaining sustained levels of protection against the against the vaccine preventable diseases such as diphtheria and toxoid tetanus. Next slide, please. One important aspect which we should not forget is if a child has been routinely vaccinated, there is no need of TT in between. So, in for DPT booster, then Tdap, they have relevant amount of tetanus. 20 IU in Tdap is also there. 40 IU in DTP is there for tetanus. So you don't have to give tetanus shots in between till 15 year. Our routine vaccination covers against tetanus also. This slide shows that significant decrease has been observed against all antibodies of Bordetella pertussis and around 4 years of age. And duration of persistence of antibodies against PT, IgA, and FHA, IgA antibodies after 4 doses of primary vaccination has shown that seropositivity has of anti-FHA antibodies reduced to 76.6 at 4 years. So the booster at this time is helpful in promoting and mitigating the ill effect of pertussis. That too, we should remember that the concentration of pertussis in the next slide we'll see that the concentration of pertussis is decreased to bare minimum in Tdap, and the risk factor associated of getting pertussis in less than 5 year is different. For a 10-year-old is different. Seropositivity of NTPT antibodies are 31.9% at 4 year and 40.5% at 6 years. So there is not much improvement. If we do not give booster, then we are going to have a rapid waning of the immunity. Next slide, please. Irrespective of the vaccination type, the waning of immunity is seen. So whole cell has 6 to 12 year, acellular has 4 to 8 year, but it wanes off. And thus the geometric mean concentration since years from school entry for dependent on the booster type is nearly similar for both acellular and whole cellular. Next slide, please. Similarly, in this slide, we have neutralizing antibody against polio virus 1, 2, and 3, and around 4 years after the gradually decline in the level of antibody against polio virus at 3 year is being shown. Thus, it is important for booster dose at the level of toddler within 3 years after administration of toddler booster dose. The utilization of inactivated polio vaccine for booster is very relevant in our clinical settings to keep India safer against polio. Next slide, please. We have covered it. Next slide, please. So, in the absence of ongoing exposure, immunity wanes over time, and this slide just reinforces that world needs booster doses to keep on preventing against vaccine preventable diseases. IAP has clearly mentioned. Next slide, please. IAP has clearly mentioned that Tdap plus DTAP plus IPV school entry boosters from 4 to 6 years, and likewise, this practice is there in nearly all nations which are working towards improving the standard of care in their nations for their for their younger populations and vulnerable populations. Next slide, please. This susceptibility of infection increases and immunity is affected, and thus we should remember that DTAP IPV is suitable for school entry and it aligns with ACVIP recommendation, and we get an immunistic response at school entry. Antibody titers are helpful in preventing these vaccine preventable infections. Next slide, please. Next slide, please. Next slide, please. It has been observed that whole cell and priming is one concept which is being utilized to improve. So some studies says that whole cell first dose lead to a good response followed by acellular priming, and DTAP IPV in acellular prime children has shown highly immunogenic outcome as compared to those children who are associated only with acellular pertussis vaccine. And those strategies are completely individualistic. ACVIP do not recommend on this aspect. The studies shows that duration from whole cell, because of involvement of Th1 and Th17 cells, has a longer protection. But comparing to side effects and the problem which the side effect can cause, it is relevant to understand that both DTAP and WP, the titles range off. We should not miss on the booster at school entry level to have a good strong immunistic response to all antigens. Next slide, please. Next slide, please. It is safe, better tolerated than wholesale pertussive with IPV, and this has comparable responses as compared to wholesale. The DTAP is associated with fewer and milder reaction as compared to the wholesale pertussis IPV. In all the parameters, this graph clearly recommends either it picks induration, redness, fever, malaise, headache, anything. The, the discomfort is more in wholesale, and thus vaccine hesitancy will be more with wholesale. Next slide, please. TDAP versus DTAP at 4 and TDAP at 10 will help in giving relevant amount of booster support. We should not forget that the big D in DTAP as compared to small d in Tdap has 10 times more component of diphtheria toxoid. Big P has more than 10 times of pertussis toxoid, and thickness is double of as compared to Tdap. So the booster at school entry level is the game changer. 4 to 6 years mandatory, 10-year mandatory, have a sustained effect of immunity, have a good immunistic response for protection against vaccine preventable diseases. Next slide, please. Next slide, please. This immunopersistence, which induces immunity, stays till early adolescence, and this has been showcased in all the subset of diphtheria, tetanus, pertussis, polio, and antibody level 1 to 5 year following school entry booster at 3.5 to 5 year. Prime with wholesale plus OPV also shows that rapid decline for all antibodies has been seen after DTAP, but protective levels of antibody were maintained at least 5 years. Next slide, please. In conclusion, AP IPV is a right fit for school entry booster, well tolerated, generate good immunogenic response, had a good immunistic response. It regardless of primary vaccine, wholesale or acellular, the magnitude of immunistic response is good. Regardless of previous vaccination schedule, boosters should be given. It helps in maintaining high immunity until adolescent. We should not forget boosters at 10 year also. And DTA IPV is better tolerated than wholesale pertussis containing vaccine. And as well, it is tolerated well in adult formulation of diphtheria vaccine as well. Next slide, please. ACVIP recommend full dose DTP and IPV at 4 to 6 years, and intramuscular inactivated polio vaccine is recommended by ACVIP. Three doses 16 14, toddlers 16 to 18, and school entry 4 to 6 as fifth boosters, and this helps in optimum immune generation at the level of complete protection for vulnerable sect of population. Kindly keep the circular vaccination intact and do not miss on booster dosage. Next slide, please. With this, I conclude my presentation, and I will take couple of questions if at all they are here, or we will take on the group. There are 6 patients waiting for my OPD, so I know you are also busy. So just if at all you have any question, feel free to ping me on the group. And I would like to thank Dr. Reddy and Sanofi to give me this opportunity to speak and share my experiences with all of you. You have been wonderful, and thank you for taking your time for from your busy schedule for today.
Thank you, sir. Thank you for giving time.
Thank you everyone for joining. Take care.